Good morning, my name is Wendy MacGregor. I'm a case manager at one of the local Dallas-Fort Worth area hospitals here in Texas. I'm here today to talk about length of stay and how it's dramatically changed over the last 20 years and what effects it's had on the hospital in regard to cost savings and why this has happened. Technology obviously over the last 20 years has had a dramatic effect on medicine, so that is contributory towards the length of stay. However, if you look at this chart here, the lines indicate different age groups of people. Back in 1980, you can see a dramatic change. This area is people over 85 years of age, where the length of stay was 12.2 days. In 2004, that dramatically dropped to just over 7 days. We ask ourselves, why did this change, and what effect did it have on cost and quality? Of note, this chart was the 1980 to 2004 National Hospital Discharge Survey annual data files, US Department of Health and Human Services, CDC, National Center for Disease Statistics. Of note, you should also know that in 1980 was when Medicare went to the prospective payer system, which dramatically changed the way hospitals were actually reimbursed for their services. Before then, people stayed in hospital through their acute illness until they recovered. In 1980, they developed a prospective payer system where diagnostic-related groups, or DRGs as they're so called, it was how the hospitals were reimbursed. For instance, if you had pneumonia, you were paid 4.2 days for an average length of stay in an acute care hospital, whether the patient stayed there for 13 days or if the patient stayed there for 2 days. You can see the rapid decline after this period of time, so one would have to think that maybe this was relative to the decrease in length of stay. Also, in the 1980s is when case management was actually introduced into hospitals, and that was not obviously coincidence. That was also to manage the length of stay of these patients. So one asks themselves, is quality affected when someone's length of stay is dramatically reduced because of cost savings? In actual fact, there was a rapid increase in rehab hospitals, skilled nursing facilities, nursing homes and home health care during this period of time to bridge the gap between when a patient is clinically ready to leave hospital and when they were actually ready to be discharged to home. So that helped with the quality aspect of things. The other thing we need to look at is, did it actually save any money for Medicare and the managed healthcare organisations? Well, from the acute hospital standpoint, yes, it did. But then if you take into account what they're paying for rehabilitation hospitals, skilled nursing hospitals and home health services, it was probably about the same. It's a matter of utilisation of appropriate resources from the hospital standpoint necessary for financial security. It's a case manager's job, therefore, to manage the length of stay in regard to that cost savings and making sure the patient can transition to a lower level of care when clinically appropriate. That leads us to, how do you effectively decrease length of stay in the hospital to save the most amount of money with the rising healthcare costs? Obviously, they've developed since this time adequate outpatient resources to do surgeries that were always done within an inpatient setting. Now it's done in an outpatient setting, so therefore cutting the cost from the hospital standpoint. And also the use of multidisciplinary teams which are orchestrated by the case manager in regards to utilising physicians, physical therapy, occupational therapy, speech therapy and dietary to have daily rounds on patients to make sure that when they're clinically able they can move to a lower level of care and out of the hospital. So this concludes my talk. Are there any questions from the audience?
Is there a single event that causes the decline in length of stay?
No, as illustrated, I think it's a combination of events. I think technology has increased within the medical field, and I feel like the advances in medicine have made it able to treat patients that were not able to be treated 20 years ago. And also surgery has become technically more competent, that decreases the length of rehabilitation post-surgery. So I think technology plays a big part, but I also feel that the prospective payer system that was introduced in 1980 had a dramatic effect on length of stay as well.
What is the benefit of multidisciplinary rounds and length of stay?
I think multidisciplinary team should be the focus of case management, and I feel like it is essentially important that everybody is all on the same page on a daily occurrence. And the hospital I work at, we do actually do daily team rounds with physical therapy, occupational therapy. The physician is on grand rounds once a week, but we do all work together as a congregated team so that we know that these patients are transitioning to a point where they can be discharged to a lower level of care or to home, depending on what the recommendations are of the team.
Has the decrease in the length of stay affected the quality of care?
Initially, before doing this research study, I would have said maybe so, because the patients felt like they were being discharged too soon, or we were looking at discharge too soon. I think with adequate education with the patients, though, and their understanding as into the transition to lower levels of care, I don't think it's necessarily going to impact quality, even though quality is a very difficult term to measure, as it were. It's almost unmeasurable to some degree, because every patient is completely different with a different set of needs. So overall, it's difficult to say whether quality is actually affected, because you have to look at the patient stay from admission all the way through the transitional care to home. But quite honestly, I feel like patients probably benefit more from a more active rehabilitation than they would get in the acute care setting anyway. And I think if patients are educated and families are educated on that transition, I think that eliminates the question of whether quality has been doubted. And that concludes, there's no other questions, that concludes my presentation. Thank you very much.